off here. All right, so to start off, can you highlight the important or most newsworthy aspects of your findings?
So what we did in this study was conduct this study among about 14 million patients in the United Kingdom and ask the question of what oral antibiotics are associated with an increased risk of kidney stones. And what we found were 5 classes of oral antibiotics, all of which are very commonly prescribed, were associated with an increased risk. Those antibiotics were sulfa drugs, which include something like Bactrim, fluoroquinolones, like Cipro, broad-spectrum penicillins, which is augmentin, nitrofurantoin, and cephalosporins, something like Keflex. So all of those drugs were associated with an increased risk of stones, but we found that the risk varied depending on what age you were exposed. So one of the important findings was the younger the age at exposure, so the younger the patient was, the greater the risk of stones. The second finding was the risk was highest within 3 to 6 months after the antibiotic exposure, but that risk continued and was sustained for up to 5 years after the antibiotic was given. That risk decreased, but it remained elevated for 3 to 5 years afterwards.
Okay. Second question, what would you say is the take-home message from the study for practitioners?
So I think the big picture here is that kidney stones are a large problem in the United States and the entire world. Kidney stones have increased in prevalence by about 70% over the last 20 to 30 years. The greatest increase has been found among adolescents and young people. And the reasons for that are not entirely known. So one of the take-home messages is that antibiotics, which are so commonly prescribed, and about 30% of the time they're not needed because they're prescribed for a viral illness, could be one of those factors that accounts for this change in the epidemiology of stones. So it may be one reason why we're seeing more patients with stones. It may be one reason why the age at which stones occur is becoming younger and younger. The second big picture is that antibiotics are so commonly prescribed, and as I was saying before, many times they're prescribed inappropriately. They're prescribed for conditions in which it's not due to bacterial infection. It may be due to a viral illness where you just need the tincture of thyme. So this should give us pause when prescribing antibiotics to make sure that the indication is correct, that they're actually prescribed for a bacterial infection, and it adds to the growing body of literature that supports the judicious use of antibiotics. So much of the work around antibiotic stewardship, the appropriate use of antibiotics, has been around emerging resistance, antibiotic resistance, but this gives us some additional insight into some of the potential harms of antibiotics because it has a direct impact on human health.
Okay. And 3, what would you say the study's implications are for that patient population?
For patients with kidney stones. So it's a great question. So kidney stones is best conceptualized as a condition that is punctuated by these symptomatic episodes that continues between and after these episodes. So kidney stones involves the deposition of minerals within the kidney, and over time those minerals build up and they may detach, causing you to go to the emergency room, maybe having surgery. And for many of those patients, those symptomatic episodes can become recurrent. What we don't know is the impact of antibiotic exposure on recurrent stones. Once you've had it, you're already likely to have more. Does exposure to these antibiotics increase that probability even more? We don't know. But certainly I think these findings indicate for anyone at risk of stone formation, and certainly for those who have had kidney stones, that if there is a alternative antibiotic that could be used that was not associated with stones, that may be a good choice to make.
Okay. Fourth question, were there any limitations of the study you can think of?
Certainly, any study has limitations. This study was conducted in what's called the Health Improvement Network, which, as I mentioned before, is a database that contains the electronic health records of about 14 million patients in the United Kingdom. So it does contain clinical information, but some of the information it doesn't contain are things like urine chemistries and stone composition. So our understanding of the causal mechanism, the causes of antibiotic causing stones, is unknown. Second, it doesn't answer what is mediating the effect of antibiotics on stones. So there could be multiple reasons for the results that we're seeing. The most obvious one is that antibiotics are known to affect the microbiome. So all those organisms that live within our body, particularly in the gut and perhaps in the urinary microbiome, and those have an impact on human health. How antibiotics impact those communities of organisms, what organisms are depleted or diminished by exposure to antibiotics, and how that affects stones, we don't know. So that's a current limitation of the study, and one that we're pursuing additional studies that are being analyzed right now that may provide some additional insight. Third, we did not study IV antibiotics, so this was only oral antibiotics, and we need to have an understanding of different doses, different formulations, different routes of administration of antibiotics, and how that may affect risk. And then finally, and I think probably this is the most important way we can extend these findings, is the kidney stones involves the interaction between all of our exposures in our life and genetic susceptibility. So stones are determined by about 50% by our genes, and that genetic susceptibility is that baseline risk. It's when we are exposed to certain things, perhaps antibiotics, certain diets, high temperatures in the environment, that you may tip over, that kidney stones may develop because of that underlying genetic susceptibility. What we don't know is, for a particular individual, given their genetic makeup, what is that interaction with our environment, with medications, with diet, that is going to cause kidney stones to form at either the individual level or the population level. So that, in my opinion, is one of the greatest unmet, or one of the greatest unanswered questions at this point.
Okay, just to touch on something you said there, the type of kidney stones were not specified by the information. Okay.
That's correct. So about 85% of stones, both in the United States and the United Kingdom, are going to be calcium-based. So most likely these reflect calcium-based, primarily calcium oxalate stones, but it certainly would include other types of stones such as uric acid, other less common stone compositions.
Okay, and you believe that the altering of the microbiome of the gut is most likely the link between the antibiotics and the kidney stones observed?
I think the urinary microbiome and the intestinal microbiome are the most likely sites in which antibiotics are acting by changing the composition of the microbiome in both of those spaces. We don't know the particular bacteria at this point, and how when you affect one bacteria, how it in turn affects the other bacteria within those communities, because it's really this living organism where an impact on one would have a downstream impact on others.
Right.
So I think that is the most plausible and most likely. Other possibilities are that you could have direct crystallization of some of these antibiotics. That's been reported for certainly sulfa drugs, but certainly not at the rate or the magnitude of risk that we observed. So there could be alternative hypotheses, but the microbiome is the one that is the most attractive and the one that many people, including our group, is pursuing.
Okay. And do you have future studies planned for analyzing the microbiome and how that might interact with the kidney stones?
Absolutely. So we're currently analyzing data from about 90 patients that include half of those with calcium oxalate stones, half of whom are age, sex, and race match controls. So it's similar to the patients in every respect, except that they didn't form stones. So we've analyzed the gut microbiome for all of those patients and are trying to understand what differences exist, both at the broad level, such as the diversity of the types of bacteria in there, and also the specific types of bacteria within the intestinal tract in these patients.
Okay. And were the antibiotics that you found were linked to the kidney stones, were they more general antibiotics, or were they geared towards specific bacterium?
So they were all somewhat broad spectrum antibiotics in that they treat a number of different types of organisms, different groups of bacteria, but there was no one common theme across of all the classes. Fluoroquinolones are often used to treat urinary tract infections, as are cephalosporins to some extent, and nitrofurantoin. Other antibiotics are not typically used for urinary tract infections, and the most common types of infections that these patients had in the study were respiratory infections, cough, upper respiratory tract infection, pneumonia. Urinary tract infection was probably, I think, 5th on the list. So a number of different diverse types of infections.